Hello. I'm so excited to join you today in learning about postpartum health. We're going to talk about mental health, and then we're going to do relational health, and then we're going to do sexual health. And we're going to talk about all the things that can help with this transition into motherhood and the things that are common, things that many people experience, and hopefully offer some psychoeducation so that this transition can be as meaningful and as smooth as possible. And I'm grateful for this opportunity to talk to you today, and I hope that it's helpful. And so we're going to talk about how taking care of the baby means taking care of you. I'm going to try a few different slides here. This is a new program for me, so give me a minute while I'm playing around. All right. So who am I? Who's this lady that's talking to us today? My name's Cami Hurst. I have a PhD in clinical sexology. I have a master's degree in marriage and family therapy. I am a licensed marriage and family therapist in Idaho. And I am also a certified sex therapist through ASECT. Here in Idaho, I am a founding member and also the current president of the Idaho Association of Sexual Health Professionals, ISHIP. And it's a multidisciplinary association for medical professionals and mental health professionals, trying to increase the competency of care for our community around sexual health issues. I'm also the host of a podcast called Sex Therapy 101. If you feel like you didn't receive enough sexual health education in your background growing up, I address some of those common issues. So that might be another place where you can connect and we can learn together. You can also follow me on Instagram and Facebook if that's your thing. If not, no worries. So right now, we're going to talk about postpartum mental health. That's this segment. This presentation is broken into 3 segments, and the first one will be postpartum mental health. And so here's some statistics about postpartum mental health. The postpartum period, we usually think about those first 6 weeks after delivery. And in those first 6 weeks, 50 to 80% of women experience baby blues. But usually that's taken care of within just the first 2 weeks of delivery. 0.1% and 0.2% of women will experience postpartum psychosis, which is much more extreme. That usually happens within the first 4 weeks following the delivery. So knowing these common time periods can also help you define with your providers what you are experiencing. Postpartum depression, however, can occur anytime during that first 12 months of delivery. So some people will say, well, I don't think it's postpartum depression because my baby is now 6 months, or why am I still experiencing it? Knowing that it can be any time in those first 12 months of delivery. And the incidence of depression among women, it usually peaks between 18 and 44 years of age. That's the incidence of normal depression, not postpartum depression. So we're kind of at double risk here if you're within those age ranges. Postpartum depression is really common. About 6.8 to 16% of women will experience postpartum depression. After those first 2 weeks of the baby blues, if it persists, it's probably not the blues any longer. And half of women are symptomatic for 6 months. And so asking ourselves to just wait might be an unrealistic expectation, because it often won't go away within a couple weeks. So if you notice it's persistent, that's a good indication to talk to your doctor. And a third of women continue to be symptomatic after 12 months if it goes untreated. So some people think it's postpartum depression. Maybe it'll wrap up after the first year, but for a third of women, it persists. especially if it's untreated. So getting treatment is actually one of the best ways to make sure that it doesn't continue to persist or increase. Here's what we're talking about, though. Here are the warning signs or the diagnostic criteria for, is what I'm experiencing postpartum depression? It's marked by a loss of pleasure in activities, by mood changes, by feeling overwhelmed, experiencing difficulty adjusting to this new role, finding it difficult to concentrate, your sleep and appetite either increasing or decreasing significantly, feeling anger and resentment toward the baby and the spouse. This is important. Depression doesn't always look like crying. Depression doesn't always look like an inability to get overwhelmed, an inability to get out of bed. Depression can look like overwhelm. It can look like anger. It can look like building resentment. So we have to get rid of the idea that depression only looks like difficulty getting out of bed or being overwhelmed and crying a lot. Those are some of the symptoms, but they're not the only symptoms. It also includes experiencing, a decrease in your self-esteem, an increase in hopelessness, an increase in helplessness, a persistent sadness or anger, irritability, wishing for accidents to relieve the burden. This is different than psychosis. This isn't wishing something. This isn't wanting to harm a baby. It looks a little bit more like wishing. Okay, little disclosure. I dealt with postpartum depression. How I experienced this was not suicidality or homicidal thoughts. It was wishing for, maybe we would get an offender bender and I'd get whiplash and I'd have to go to the hospital and someone would take care of me and someone would take care of the baby. It's this fantasy that would alleviate our overwhelm. This fantasy that might be what's needed in order to get help here because I was unable to ask for help myself. Then it can progress, though, to thoughts of harming yourself or harming your baby. And that gets a little closer to the psychosis that we talk about. So we're talking about this on a spectrum, and these symptoms increase the severity of the postpartum depression we're experiencing. There are some risk factors. Here are, some statistics about women who are more at risk than others for postpartum depression. If there's difficulty in the child care that you maybe were expecting or weren't expecting, a child who has a difficult time latching, there's a feeding issue, maybe there's some difficulty with the baby swallowing or the latching, if they're having very difficult time sleeping, or if there's a health complication, you weren't anticipating they needed to be in the ICU, or you were, and the reality is setting in and it's much more difficult. These women are more at risk of postpartum depression. Women who don't have very much social support, either family support or social support in this transition. When there are stressful life events happening at the same time as this transition to motherhood, a change in jobs, moving across the country, maybe someone's getting deployed, and the financial stress that comes along with it. If there's a history of family depression or anxiety, that's going to increase your likelihood. If there is previous postpartum depression with another pregnancy, your risk for the secondary or third pregnancy to also have postpartum depression increases greatly. And if women experience the baby blues after the delivery, that increases the risk that those blues turn into depression. Now, here's some obstacles to treatment. Some women are unable to recognize that they're depressed because we may not know what depression can look like. And if we aren't, meeting those stereotypical symptoms, we explain it away, that it must not be depression. Some believe that these symptoms are normal. We just have to wait. These are not normal symptoms. They might be common, but that doesn't mean normal, and that doesn't mean healthy to be experiencing. Just because many women experience postpartum depression does not mean you should excuse your symptoms. It does not mean you shouldn't seek help. Some women are fearful of being labeled a bad mother if they, take on this label. And so there's a bit of denial about what they're experiencing because they're worried that it won't meet this society's picture of the bliss, being in maternal bliss. And some women are worried that it may limit their parenting ability. That what if the baby gets taken away from me? What if they think I'm crazy? What if I lose my child? Luckily, in the country, we have so much experience in postpartum depression that might be a fear, but it isn't usually carried out the way we're scared it might. We know how to help women as mental health providers and your medical providers. So your options for treatment are pharmacological treatments. When you talk to your doctor, we have great options now. And of course, reaching out for help for counseling, either individual counseling for you specifically or some type of group support that offers group counseling for new mothers. And there are support groups, which are different than counseling. Support groups are more groups of friends sharing some information and sharing friendship. That's different than group counseling, which requires a licensed therapist to lead that. So before we move on to postpartum relational health, take a minute and look over these slides and think about what was new to you, what was unexpected. Take a look at those symptoms. Share them with your support system. If you have a partner or family or friends, ask them to help you keep your eyes open to these symptoms. Ask them to be an advocate with you if they notice you experiencing any of this. Set up a plan for if this is part of our birth story, how are we going to handle it? Often that can reduce the anxiety when the symptoms come up because you already have a plan in place. You already know who's going to be on your team. You already know who's going to support you in implementing that plan. So share this information about risk factors for postpartum depression. Research the treatment options that you are most likely to enjoy. And continue talking to your friends and family as you transition. Our mental health really impacts the health of that baby. And the more you take care of you and your mental health, the better that baby will develop. And, prioritizing or glamorizing the sacrifice of the mother as goodness doesn't play out in our research. So being the sacrificial lamb for your children will not create a more developed child. Take care of you. Prioritize your health. You being healthy really does translate to the baby being healthy. So internalize that, have a good discussion, talk about the risk factors, talk about a plan, and hopefully this will decrease any anxiety you might have about postpartum depression as you look forward to meeting your little one. All right, we're going to jump in now to the second portion, which is relational health, the relationship between you and your partner. Again, who am I? If we break this video up into 3 different segments, or you weren't with us for the first segment, my name is Cami Hurst. I have a PhD in clinical sexology. I am an ASEX certified sex therapist. I have my master's degree in marriage and family therapy, and I'm an Idaho licensed marriage and family therapist. I am the founder and president of an organization over here in Idaho for sexual health professionals. And I have a podcast where I weekly do some psychoeducation around sexual health. It's called Sex Therapy 101. You can find it on all platforms. So we need to talk a little bit about this transition not being just a transition for you, but a transition for you and your partner. This research is coming from the Gottman Institute. They've done a fantastic research about the adjustments into family life. So often the partner is experiencing some financial stress over providing for more people, more needs. They also experience a lack of sleep and fatigue. For both parties, there's increased chores and housework. For both parties, there's a new experience of dealing with in-laws and their involvement in your life because it increases now that there's a baby. There is a significant loss of free time for self and for social activities for both of you. There is usually a decline in sexual interest that appears, if it hasn't before, that needs to be addressed. And there's often some disagreement about these new roles, about how this is all going to work. Now, issues for the mother relationally are often this lack of sleep and fatigue that enters for a period of time. They will often experience personal doubts about their competency, about their skills. The mother will have unpredictable shifts in mood and anxiety, both because they're learning something new and because your body is completely changing from a human-making machine back into just sustaining life for yourself. There's an increased responsibility, an increase in home labor, individual stress about these new roles and responsibilities, and often a change in work situation. So these relational transitions look like needing to adjust and accept that there's a new member in the system. Now, instead of just it being 2 people in the system, there's 3 or 4 or 5. The system will change. And the couple must alter their relationship to make room for this new child. When there's an introduction of baby, it also impacts their, extended family situation. Now this couple moves up a generation by becoming parents. They're no longer the children. They now join the ranks of other parents. And this often creates a change in self-image and identity. And so you're also shifting your self-perception as you add a child. It changes your identity and how you think of yourself. So this is pretty small font, but I want to go through these because they're really important. Though both parents will work much harder after the birth of the child, both tend to feel unappreciated. So it's important to realize that that's common, that both may feel unappreciated for their effort. In the year following the baby's arrival, the frequency and intensity of relationship conflicts increases significantly. So if you had a difficult time dealing with conflict, you're going to want to have a strategy because it will probably increase. That third bullet point, mom's sexual desire tends to drop considerably. Her body knows it's not a good time to get pregnant. And as far as evolution goes, desire has been to maintain procreation. And so desire will drop. Your body's working for you. It's saying this would not be a good time to make another human. I'm not ready yet. And so we're going to have to address that reality of a drop in sex drive. It will normally stay low throughout the baby's first year of life, particularly if you're nursing, because those hormones keep telling your body, nope, we're still taking care of another human. It wouldn't be a good idea. We don't have the resources to create another human at this time. And not only will desire drop, but frequency will drop because the couple doesn't have a new script for when we have sex because our evenings are disjointed. We're not alone very often. We are going to get interrupted by children, and it's a new transition that way. Moms usually get very involved with the baby and are too fatigued to offer their partners much in the way of emotional connection. We've got to have a strategy as a couple to take this seriously without taking it personally, without blaming, and without defense. Mom and dads both undergo enormous changes in their own identity. They go from thinking of themselves not only as parents, but as members of greater family, brothers, sisters, sons, daughters. Parents often find their values changing along with their goals in life. It's really common when we change the system, that we start to change values or we start to change goals, different things become important, different things become prioritized. So don't be alarmed if you or your partner who used to be so committed to one thing that starts to be less of a priority, or you change your mind about something after you experience it. You may know now before the baby gets here how you're going to raise it. And once it gets here, you may reevaluate. You may change your mind. You may want to do things different than you thought you did. And that is all normal. Give each other permission to change your mind or to think new thoughts or to have new goals or to have new values. That's very normal. That's not something going wrong. That's something going right. Couples often want to be better parents for their children than their own parents were with them. And so sometimes there can be a critical eye that enters at this period, some judgment of your parents if I don't want to do it that way. And we don't need to find this as threatening. Realize that this is normal to want to do it a better way and to be taking evaluation of how you were raised and maybe wanting to change some things. And that doesn't mean we have to cut people out of our life, but that we can, really embrace the hopes we have for this children and mourn for ourselves things that we weren't given. That mourning period that produces new goals for our children, our own parenting ideas, can be a process, so we can be patient with each other. As the relationship changes, it begins to take on a different life. We start to think about before baby, after baby. Before baby, life was like this. After baby, life was like this. And it becomes a marker in our timeline where we mark the events of our life. As soon as the baby's born, it's very, very common for mom's friends to arrive on the scene. The society of women who've come to help, and new dads can often feel excluded or crowded out. And they're more likely to respond by removing themselves from the situation. Oh, the women got here, I'll withdraw. Oh, her friends are here, I'll withdraw. And they can, withdraw from baby and mom, not sure what their place is, trying to avoid conflict. It's important that we make room for both parents, that we listen to the difficulties of both parents, that we recognize that the whole family is going through a new change and the whole family will need support, not just mom, but the partner as well. When mom's unhappy, let's see, I'm sorry. A gulf can sometimes develop between partners, and maybe some possessiveness of the right way to do things. That's very common. And having a plan of how are we going to address when we want to do things differently with the baby. Having a game plan for that conflict can be really helpful. And here's some tips for managing healthy conflict, because we know it tends to increase. How are we going to deal with it? Learn how to soften the beginning of a discussion. I'll often teach my clients to say, because, which is setting the intention of why you're bringing this up. Because you are so important to me, I want to talk about. Because this going well for both of us is a main priority, I want to bring something up. That's a softer way to start a discussion. Accept the influence of each other by practicing the idea that there's more than one way to do things. Embracing the idea that there's a dozen good ways to get a baby changed. There's a dozen good ways to get a baby fed. There's a dozen good ways to get a baby to sleep. There's a dozen good ways to make a baby smile. There's a dozen good ways to nurture a baby. There's my way. There's my partner's way. There's our mother-in-law's way. And allowing some versatility for goodness. Not getting so rigid about a certain way to do things. Learning how to practice your own psychological self-soothing. Hopefully, as parents of this baby, you both have some strategies of what to do when you're anxious or when you're in conflict. That's an incredible skill to be able to develop. Hopefully, you're learning the art of compromise through this. Um, Setting up some fair fighting rules about when and how you'll engage in a conversation. Deciding that we'll have this conversation when we're both calmed down. That's a fantastic rule for both of you to embrace. Deciding on what conversation you need to have rather than fighting it out. Say, hold on, one topic at a time. What are we trying to discuss? When will we know that we've got an outcome and that we're on the same page? We've made a decision. Gridlock is what we call conversations that go nowhere, that get unresolved over and over and over. And it's common for couples when a baby arrives to start to see, oh, we've got some gridlock issues. There are one or two or three, hopefully not 20 topics in which we don't resolve well. The more those grow, the more you may need to look into conflict management and communication education. Most couples throughout their lifetime will have a chronic 1 or 2 or 3 gridlock topics, but you should have experience with a dozen where you resolve. So if every conversation feels like gridlock, you may need some extended help with education or couples therapy. It can be helpful to intentionally create the new roles, new rituals, and new traditions. All voids need filled. Look at the voids that come with a transition to parenthood, maybe a loss of a role at work, maybe a loss of a career, maybe a loss of your identity as a individual. Realize that those need to be filled with something new. It's the laws of physics. So what are we going to replace the losses with? Another idea is keep the discussion about roles on the table, realizing that this is a transition period. We're moving from life to before to life after, and we might have an idea of what our roles, rituals, and traditions should be, but leave them on the table, make them, in pencil. Allow there to be flexibility. Allow there to be changes and experimentations. If we want to try this routine, we want to try it for a week. We'll decide then how it goes. It didn't go well. We're going to try something new. Instead of being rigid to the roles you talked about before baby came on board. Create new rituals as a new unit. What are the rituals you want for your family? What do you dream about new traditions? What are the things from the older generation that you want to make sure you continue? And what are some new things you want to try? Keep sharing family stories together. This will cement you as a new group. Groups, families, units, they have a narrative about how they came together and how they overcame hardship and how they went through these changes. So this is the beginning of not just your couple story, but your family story. Keep sharing stories. And realize that now, instead of there's a lot more relationships introduced. There's the family unit, but there's also a relationship between baby and mom, a relationship between baby and the partner, a relationship between both partners, now a new relationship between maybe siblings and the baby, new relationships between in-laws and the baby. So many relationships now are introduced with just one person. Give yourself time to adjust to all those roles, to all those new relationships. It's not just the addition of one person, it's the addition of a dozen different relationships. Prioritize the adult relationship between mom and dad or partner and partner. Bizarrely enough, this is a quote from John Gottman, bizarrely enough, given common beliefs about the difficulties of the transition to parenthood, what separates blissful mothers from the rest is not the baby's ability to sleep soundly, it's not the baby's nursing style, or the amount of time parents get to spend at home. The main determining factor of whether or not the husband joins his wife is the difference. That makes the difference. That makes this a deeply emotional and demanding journey. So the mother's happiness is very directly correlated to the partner joining mom as an equal partner in raising the baby. That's important to realize. All right, now we're going to switch gears and talk about postpartum sexual health. Okay, this is my main forte, where most of my specialty lies. Who am I? If you didn't join us for the first 2 segments of this presentation, my name is Cami Hurst. I have a PhD in clinical sexology. I am an ASECT certified sex therapist. I'm licensed in the state of Idaho as a marriage and family therapist, and I do have a master's degree in marriage and family therapy, and I do quite a bit of couples work and family work. I'm the founding member of ISHP, which is the Idaho Association of Sexual Health Professionals. And I have a weekly sex therapy podcast where I do psychoeducation about sexual health, because most of us didn't get any. And what we did get might be part of the problem. So you can find me there if you'd like to increase your sexual health knowledge. So what impacts our sexual development as humans? Part of it's biological, our hormones, whether or not there's pain, whether or not we get the right kind of stimulation. Some of it is sociocultural, the families we came from, the churches we came from, the communities we came from. They all have norms and ideas and expectations and teachings that may or may not be helpful. Our psychological health, whether or not we have trauma, whether or not there's some repression or obsession. If we experience depression and anxiety, those impact our sexual experience. And then the relationships that we're a part of, whether or not there's non-sexual affection, whether or not the climate of the relationship is enjoyable, your own sexual history, and the seasonal roles you're in. Specifically, we're talking about the seasonal role of adjusting to the new baby at home. There will be some physical reproductive changes after baby. Healing and discharge of leftover blood and uterine tissue. This usually stops after about 6 weeks, but you can expect some, whether or not you have a vaginal or a cesarean delivery, you will experience discharge of tissue for about 6 weeks. That's not unusual. During this time, you're encouraged, whether or not you had a vaginal or cesarean C-section, to not insert anything into the vaginal canal for 6 weeks. That doesn't mean you can't have sex for 6 weeks. It's a problem that most of us define sex as a penis in a vagina, but there are many ways to connect and enjoy sexual intimacy without intercourse. And this might mean exploring outer course during that time, where the partner can still have an orgasm. You can still have an orgasm. There doesn't need to be anything in the vaginal canal for you to touch, connect, and even seek orgasm together. The skin around any incisions that you have will be sore and stiff. As that heals, you may develop scar tissue. Scar tissue is not flexible, and yet our sexual organs need to be flexible. So there's some things to think about when there's incisions, and also how they are treated and how extreme they were. You might experience a difference in lubrication. Okay, so maybe it was really easy for you to lubricate before. Now after baby, you might find that you're more dry. This is the easiest problem to fix. Lube will be your best friend during this time. Your body is putting much more energy into healing than it is into moisturizing. Moisturizing takes a back seat as a priority for your body, and healing takes the front seat. You please do not play through any pain. If something is painful, don't get it in your mind that you just need to push through it so it'll be better next time. That can create additional micro tears, additional stress on an incision. It's important to take this slow and gradual. You may even experiment with some tampons or your finger or some toys to just know exactly the kind of pressure, girth and depth your body can handle so that you're the expert, so that you'll know before you start to initiate with your partner what will work and what won't work. It's important that you seek pelvic floor physical therapy or pelvic floor care. The United States is the only first world country that does not provide for pelvic floor physical therapy after a vaginal or cesarean birth. It's so sad. A sprained ankle receives more physical therapy than our body that just carried, created, and delivered a human. And it's not just for vaginal births. If you have a cesarean C-section, your pelvic floor still needs all the treatment that a vaginal birth needed. There's often a distortion between the vagina and the perineum, which is the area between the vagina and the anus. That is where any tearing usually occurs, or episiotomies. And that can take some care so that we heal with as little scar tissue as possible, because scar tissue is not flexible. There's often a heaviness or a dragging sensation as the uterus returns to its pre-pregnancy state. And for many of us, it doesn't get completely back to the pre-pregnancy state without pelvic floor physical therapy. So find out who those people are in your area. It's more than just Kegels. Kegels on your own, most of them do them wrong. And sometimes when our pelvic floor is healing, we can get off center. So this ligament goes tight and this is lax. If we do Kegels, that keeps the problem there. And so we may need to learn to relax one ligament and tighten another. And so it's quite the science. Reading an article and doing Kegels at home is not the same as pelvic floor physical therapy. They will also help you identify any points of pain vaginally or in the perineum or in the vulva that needs to be addressed. And that can also help with any rectal seal or bladder prolapse that can happen after a pregnancy. Pelvic floor physical therapy will help with how the pregnancy impacted our bowels and our bladder. Again, please don't play through the pain. Focus on intimacy, not intercourse. Focus on outer course and pleasure and comfort and enjoyment. Embrace the role of lube. It is not a personal shortcoming to need some added moisturization. It will add to both of your enjoyment, and it is absolutely not a moral failing at all. Please start slow. Please practice consent. How's this feeling? Do you like that? And realize that things will change. What you liked before, you might not like anymore. You may need to do some things different during this time of transition. So be sexually flexible. Pay attention to your body. It's trying to tell you something. If there is pain, it needs your attention to be resolved. Ignoring it will often lead to the pain getting louder. Okay? Please don't ignore any pain that you might experience. Form a team if you need to. If this becomes really overwhelming and difficult, form a team with a pelvic floor physical therapist and a sex therapist if you need to. And know that your OBGYN might not be super helpful in this area. Most medical professionals, specifically OBGYNs, were only required to have a 9-hour seminar on sexual functioning so they can deliver the baby safely. They can put your bladder in a sling safely. They can do the pharmacological part of postpartum depression, but they don't necessarily understand sexual dysfunction very well or the pelvic floor very well. So it's important to have a team of 3 experts because the OB is not the expert in this situation. They got the baby here safely. You and the baby hopefully are safe. That's their goal. And as far as sexual functioning goes, the OB will not be the expert. There's some common concerns about resuming intercourse after both a cesarean or a vaginal delivery. Here's some things that are commonly heard, some quotes. We tried a few times to have sex and just couldn't do it. like physically couldn't do it because of the pain, which has really turned me off to sex for a while. So going to this postpartum sexual experience, knowing we may have to be flexible, knowing we might not be able to experience intercourse. If we expect that we have to adjust, hopefully we won't just shut off. Second quote, it's scary. It's like you don't know what's going on down there because you feel like it's all injured. I believe that that's true. The entire area experienced quite a bit of trauma, right? We're icing the entire vulva and perineum. We're taking pain relievers sometimes for the entire area. So it can be helpful to get a mirror and to know where your episiotomy is so that you can tell your partner to avoid maybe the bottom half or bottom third of your vulva. It's important to know exactly where the damage is and to be the expert of your own body to say, oh, the upper third is totally pain-free. Let's stay there and stimulate each other as far as outer course goes. Be the expert of your own body. Grab a mirror, use your finger, do some light pressure exploration so that you know exactly what's healing and what's not. Third quote, I'm still extremely conscious of the pain whenever we have sex, even now. And it's not painful now, but I'm anxious about it being painful. That's exactly why we don't want to play through the pain, is you will develop a tensing response, even if the pain isn't present, that we can have to unlearn over time. So from the beginning, just making an agreement between you and your partner that you'll be in charge, that you'll know what's painful so that you don't have to have any traumatic or really difficult experiences. That's why it's so important to not play through the pain, is because it can then create some avoidance and some tensing in the future that will create more problems. That fourth quote, I guess I went from having a very healthy sex drive and a very healthy libido and interest in sex to being completely disinterested. Completely. No interest. No physical, no nothing. So whether that came from headspace or whether it was physical or hormonal, I don't actually know. It's likely all three. It's common for the desire to decrease. It's common for the added responsibility to make you mentally engaged. You have a new relationship with your body. Often it's difficult to move from a dual, like our body served one purpose sexually, our breasts were for attraction. We enjoyed these things. And now our body's playing two roles. We're also very practically feeding our child. And so sometimes what we eroticized about our own bodies or our partner's body changes. And we're like, wait, how do I deal with this dual meaning now of my vulva, my vagina, my breasts? And learning how to have two things be true at once, that they are both erotic and enjoyable parts of your body, but they're also practical parts of your body. So that changing of your self-concept is really common. The fifth quote, let's see. These days I'm just so tired. I feel like I could go without sex forever. Fatigue definitely influences desire. Expect it to drop when you're tired. That's not something going wrong with the relationship. That's something going right with your body. Our body cannot operate on 100, can't fluctuate. It can't function at 100% capacity for everything at once. And so it's focusing its energy on breastfeeding, on healing, on a different sleep schedule. And of course, it makes sense that your body is saying, I don't have the energy to make hormones to provide sex. And so please expect it and plan around it so that you're not shocked or your partner is not shocked when this changes. And remember that this is a transition. We have before baby and we'll have after baby, but right now we're dealing and transitioning usually a 12-month period of learning to live with baby. Our roles are expanding. For some women, but not all, motherhood and sexuality are experienced as contradictory. That mothers are not sexy. That can, or mothers should not be interested in things that are sexual, or a partner might have a hard time. I'm having a hard time thinking of you that way because, we put mothers on this wholesome pedestal and we put sexuality down somewhere else and it doesn't match. This is a really common cognitive dissonance for people to experience. That second quote. I think it's because it's harder to see myself as a sexual being, to tell you the truth. This is me. This is what I do every day. I look after children. I clean up. I just really feel mundane. And how could you find this attractive? It doesn't feel sexy. We're going to address that in the next slide. And that last quote, I suppose I've lost the confidence just knowing that I'm mom. Maybe for me, it's taken a lot of sex appeal out of me as a woman. I don't see myself as sexy anymore because I know that I'm a mom. And those ideas for some people aren't in conflict. And so it creates a whole new neural pathway for moms to be nurturing and sexy at the same time. So what do we know diminishes desire? This now is coming, we're switching from Gottman research to the research of Esther Perel. We know some things about what diminishes desire. Too much familiarity, too much comfort. When we first get together, seeing each other, seeing your partner in their underwear could be really hot. But when you see it every day, day in and day out, it's too familiar. It's no longer a turn on, okay? So sometimes we have to plan around that. Feeling bored or having emotional disengagement will decrease desire. A lack of novelty, having the same script over and over and over with little variation diminishes desire. The transition to motherhood is the most common time women experience a decrease in their sexual desire. Busy, stressful lives, the de-eroticization of our partner, right? Seeing them as common, mundane, too familiar. The contrived illusion of safety sometimes, and also the over-domestication. I find this one really interesting. So it's not quite accurate to say the woman experiences a decrease in desire. It's over-domestication. So when we look at the research of same-sex couples, whoever is staying home doing the domestic work often experiences a decrease in desire. So it's not about gender, it's about who's doing the domestic work. So how are we going to combat that? What maintains desire? Having fluid communication about intimacy and emotional differentiation. Differentiation is this idea that I'm balancing what I need with what you need, that they're imbalanced, that they are equally prioritized. Any type of codependency or fusion in the relationship is going to work against desire. So maintaining that we are a balance of power, I'll say it, maintains desire. Validating each other, letting each other know you see each other's work, each other's efforts, each other's struggles, that maintains desire. Having a little bit of space to still remember who you are as an individual will maintain desire. When we fuse and enmesh with another person, sexual desire decreases. So maintaining the sense of what makes you unique, still going to, voice lessons or whatever, still playing your guitar or still having poker nights, whatever it is that, maintains who you are as a separate individual, that honors your uniqueness, that will help maintain the desire. Playfulness, novelty, curiosity. This is a new stage, so we could make it fun. We could try some things we haven't tried before. If you've never spent much time on outer course, you've always just done the intercourse script, this could be a good excuse to try some new things playfully. Our perception of our partner, allowing them to also maintain their differentness will keep them attractive to us. We may need to use some fantasy and some imagination in this time period. You may need to play with the idea of how you felt about your body in the past, if you're having a difficulty with your body changes now, and that's an okay thing to do. Stay out of the bed. That means make it more novel. Maybe you find if your bedroom has become baby central, you've got a crib and the changing table and all that, maybe you move to a guest room, have sex in places where you're not constantly reminded of this new role. And permission to explore new things. Some partners don't give each other permission to explore. We find it threatening. We worry that it means something about the relationship, and that can often diminish desire. Here's an idea that's really helpful, I think, for women who experience a change in their desire. This is coming from the research of the Kinsey Institute and made popular by Emily Nagoski. It's this idea that sexual desire has two controls, much like a car, where there are brakes and there's gas. And far too often, we're looking for, what are my turn-ons? What's the gas? Let's put all the effort on the gas. But it's important to recognize that if the brakes are on in a car, it doesn't matter how much we stomp on the gas, we are not going to move anywhere. We're going to be frustrated. We're going to maybe damage the engine. We're going to burn up fuel, and we're not going to move anywhere. It's the same with sexual desire. We found that if we can put energy on releasing the brakes, that is more efficient for us than stomping on the gas. So think about that. Begin to understand yourself. What are my sexual brakes? What are the things that make me say, not today? And putting our energy toward alleviating those is much more efficient and effective. So communicate them with your partner. When you realize, when I wake up 6 times a night, I do not have the energy. Okay, so now it can be us against it. It can be us as a couple against 6 times at night. And we brainstorm, how do we alleviate these breaks so that hopefully your desire will start to return to normal over a 12-month period of time. Set that expectation out. This is a process over a year. It's not, okay, you got 1 night of sleep, so hopefully your sex drive has returned. Okay, push the expectancy out, that it's not immediate result for effort, but over the long term, there's going to be progress. That can be very helpful. Maybe embracing sexuality as part of your wholeness. Realizing that all the parts of the pie that make us a human being deserve equal effort and attention. And sometimes when motherhood is a piece of the pie that's introduced, we replace the sexual piece of the pie with the motherhood piece of the pie, instead of saying, we're growing, we've got a new piece of pie, and my sexual self is still important, my emotional self still important, my social self still important. And resisting the urge for motherhood to take over your whole self. I'm hoping that these 3 presentations were helpful. I'm on your team. I'm hoping that this transition to motherhood is a one of growth, one of support. And while there will be adjustment, I hope that what we talked about our mental health postpartum, the relational health postpartum, and sexual health postpartum, I hope it will be an important part of your journey and contribute to the smoothness in which you experience this transition. Thanks for having me. If you'd like to know more about my work, here is my website. It's CamiHurst.com. You can learn a lot more at Sex Therapy 101. That podcast is on all the platforms, and I am on Instagram and Facebook. So it was good to learn together with you, and I hope that this was valuable. Take care of yourself so that you can take care of your baby. Bye-bye.